welcome to Conversations in Interventional Cardiology. My name is David Rizik. I am the Associate Editor of SCAI and Chief Scientific Officer at the Honor Health Medical Centers in Scottsdale, Arizona. I'm honored to represent SCAI and especially Editor-in-Chief Dr. Alexandra Lansky. We are here today to discuss what has become an evolving and very important document published in SCAI entitled Radiation Exposure and Protection for Assumed Pregnant Interventional Cardiologists and Electrophysiologists. And I am joined by an esteemed panel of thought leaders in this area. We have Kenneth Fetterly, medical physicist and associate professor of medicine at the Mayo Clinic in Rochester. His co-author, Mayra Guerrero, also a professor of medicine at the Mayo Clinic. Celina Yong, a longtime friend and someone who's expert in this area. She's director of interventional cardiology at the Palo Alto VA and a professor at Stanford. And also Holly Bauser-Heaton, associate professor at Emory University of Medicine. She's a pediatric cardiologist at the Children's Healthcare of Atlanta Cardiology in Atlanta, Georgia. And I would very, very much like to thank each one of you for joining us and taking time to be a part of this. Dr. Fetterly, I'm going to turn it over to you. Maybe you could take us through this recent publication.
Sure. Thank you, Dr. Rizik. First, I'd like to start by acknowledging that this was a collaborative work by several of us in the cardiac cath lab, but also including colleagues from radiology and from radiation safety. So the motivation of our work starts with the fact that scatter radiation from the patient and the X-ray tube contributes to occupational radiation exposure, including fetus exposure. Most all of us know that. However, there's still a fair bit of uncertainty about the fetus radiation dose for interventional cardiologists, and concern about fetus radiation dose has been identified by several works as a barrier for women considering careers in cardiology. So the purpose of this work was to measure radiation exposure behind the radioprotective aprons in a diverse invasive cardiology practice, and use those exposure measurements to estimate fetus radiation dose for an interventional cardiologist. And really, we hope to contribute relevant data to the literature to help female trainees make informed decisions about interventional cardiology. So very briefly, our methods were to insert small dosimeters into pockets made of radioprotective materials. So on the left side of the screen here, you see some little radiation dosimeters, and those colored pockets are made of various thicknesses of radioprotective material from 0 to 2.5, 0.35, and 0.5 millimeters. Now I'm going to show you some results later today, only for the 0.5 millimeter lead apron thickness. Our primary endpoints were 40-week exposure in terms of milligray. And then today I'm going to share with you some fetus dose estimates, assuming that the participants in this study were in fact pregnant during the study. The 42 participants wore these dosimeters on the outside of their apron for about a 6-month period, and then we retrieved them and read the radiation exposure from them and extended or extrapolated those values to a 40-week exposure term. We enrolled 42 interventional cardiologists. They were from the cath and EP and device practices. They were both fellows and staff consultants. And 11 of the participants were female, 31 of them were male. And these particular 3 descriptors had no statistical effect on the results of this work. So here's our main result that I want to share with you. Plotted on the y-axis is the estimated fetus dose. We took that exposure reading to the abdomen behind the 0.5 millimeter apron, and then used that to estimate fetus dose, assuming that, again, that each of these 42 participants was in fact pregnant. So the y-axis is that estimated fetus dose. I've separated here in this graph. Females have a red symbol and males have a blue symbol. There was no statistically significant difference between the two. I just wanted to show you where the different groups lie on the data plot. The x-axis here is the accumulated Kerma area product or dose area product delivered to patients by those individual participants. And what you'll see with the dashed line is that there is an anticipated increase in the estimated fetus dose as the patient exposure increases. That's the natural known effect of increasing patient dose increases occupational radiation dose as well. Above that on the chart, there's a few reference values. The green bar indicates the approximate estimated fetus dose in the US just due to natural background radiation, which ranges from about 0.7 to about 1.4 millisieverts in a 40-week period. The pink line refers to the European ICRP fetus dose limit of 1 millisievert, and way off the chart somewhere, the top of the chart is 2 millisieverts. Off the top of the chart is the US NCRP fetus dose limit of 5 millisieverts. So I put those on for reference values to help indicate how modest these fetus dose measurements or these estimated fetus dose values were. Off to the right-hand side, we came up with a little tool to, if somebody wants to try to forecast what their fetus dose might be, if they were to become pregnant, they could identify their collar badge reading, the collar badge that you all wear all the time, divide that by 20, make sure you're working in units of millisieverts, and that would be an approximation of what fetus dose might be for you in your clinical practice sometime in the future. Just some comments about why we think this is relevant. This shows really that fetus radiation dose in this diverse and relatively busy educational institution can be maintained to very low levels. This wasn't a radiation shielding study, but it's really important to use the upper and lower body shields routinely. And for pregnant people, we still recommend to wear a 0.5 millimeter non-lead apron. Now, this occupational exposure, these values are low. The predicted radiation risk from a 0.5 millisievert dose to the fetus, which is approximately the highest that we saw in this study, is about 0.005%, a really low number, sort of the predicted or estimated risk. And just to remind us all that approximately 10% of identified or known pregnancies result in early termination naturally. 3% of them or so also have a major fetal anomaly. And so this value of 0.005 is really quite low in the context of those other known risks to pregnancy. And then finally, I think we have a chance here to kind of change the narrative about radiation for safety from radiation is dangerous, and maybe back it down a little bit and talk about how we can work safely with radiation. I hope that this data that we contribute to the literature helps to support that transition. So that's all I have for prepared remarks.
Very, very interesting. That's great stuff. Radiation safety is remarkable. I've heard editors of journals say that publishing papers in major journals on radiation has not been popular, and that is changing because of studies like this and some of the advanced protection strategies that seem to be gaining interest. Mayra, a lot of male subjects, more males than females, if I saw that slide right. Extrapolating from a 75 or 80 kilo male to a 7-month pregnant female, I was concerned about that when I read this. One of the things that I have discussed with many female interventionalists is that the lead fits females differently than it fits males, that maybe historically lead was fitted for males. Now you're extrapolating from a male patient to a 6 or 7 or 8 month pregnant female. Can we do that? Do you think we can do that safely and reliably?
I think so. I think that each of us, whether we believe we can be pregnant or not, need to make sure that what we're wearing fits properly and we're protecting the most important parts of our body. And I think each of us need to customize that regardless. So I think we can. There's also, we haven't mentioned here the possible addition of another layer. I personally wore 2 layers, and this data is reassuring because it tells me that what I did when I was pregnant was unnecessary, perhaps, because I wore 2 skirts, so like 4 layers, and then on top the apron for pregnant workers. And so it was like 5 layers. So maybe that was not necessary. But
there's some orthopedic issues related to to pregnancy. I remember my wife going through some of them. Does that added layer of lead possibly predispose to other orthopedic related issues during pregnancy?
It's possible. It's like you have to pick your battles. I think with this data, we no longer need to perhaps recommend that there's double layer or like 5 layers like I did. So that's reassuring. So I think this data suggests that the regular standard apron, provided that it fits properly, should be enough. And it can be a choice to wear a second one, but at the expense of other side effects like back pain and orthopedic problems.
Holly, does this, the first 3 months to me are very important months. These are the months of organogenesis. Do these data make you feel more comfortable about the fetus exposure during those months of organogenesis?
It really does. And part of this is, we look at this data as suspected pregnant. Many of us don't know that we're pregnant during the very early portions of organogenesis. And so this was very reassuring to me. I think a lot about my patient population, which is a little different than maybe everybody on the panel. We're cathing patients who are premature, barely viable now. And so the radiation exposure going to them is significant. So again, I think this is very reassuring that we're talking about these low doses for a 500-gram baby. That's still kind of a fetus. So it's important for the work that we do too.
So if I can read into what you're saying, this is not something we should be doing special when we find out somebody's pregnant. These are everyday practices that we should be methodical and meticulous in employing. Is that correct?
That's exactly right. And I think, the other lesson that we've all learned over time is, ALARA is a principle. However, we really can do a lot of reduction strategies for not only radiation to our patients, but to us as well and everyone in the room. One of the things this paper talked about, and I'm very grateful, talked about, maintaining, retaining females in interventional cardiology. But I think we have to remember our staff too. And our staff doesn't always have the choice to choose to be in the cath lab, and many of our staff are female. So again, very reassuring to think about best practices for everyone in the cath lab.
Celina, you've done some of the seminal work on this topic of women potentially seeing radiation exposure during childbearing years as a barrier to a career choice. How more than 50%, Celina, of the women in medical, more than 50% of the students in medical school are women, yet a fraction of those individuals are going into interventional cardiology. Does this adequately address this? Does this put this in the rearview mirror? Give me some perspective on that.
You're right, David. When you look at interventional cardiology compared to all the other medical specialties, for a long time, we have ranked right there at the bottom, and in terms of gender representation. And when you compare us to other sort of traditionally male-dominated fields like orthopedic surgery, urology, who have made significant strides in recent years, I think the problem we've been dealing with is that, unlike these other fields, as a condition of our job, there's a degree of radiation exposure. So I think that really just underscores the importance of studies like this to give us real numbers and reassure us that these numbers really are low. And that can help us get our minds around it. You referred to an ACC study I did a few years ago where we surveyed more than 570 fellows in training from around the country and asked them what the deterrents to pursuing a career in interventional cardiology were. And there were some interesting differences by gender. And one of the most important things that came out for women was concern about radiation during childbearing years. And interestingly, there was a secondary issue that was also very important, and it was the physical burdens of a career in interventional cardiology. And so it's almost a multifactorial hit against women who are interested in this field. So very important issues.
And how do we know that the tolerances of a developing fetus? How do we know what a fetus can tolerate and what a fetus can't tolerate? I mean, do we have really strong data, published data on that?
Well, that is a very tough question because when you look at the data from the study, for example, you can see that the numbers look great. They're far below both the international and the national recommendations. But some of us will ask, well, what are those recommendations based on? And when you dive into it, really they're based on things like extrapolations from Hiroshima and the fact that the international recommendations don't match the national ones, and that there are other countries that don't even allow pregnant women into the cath lab, can raise some questions about how strongly do we feel about this data, and what is the right amount. I think you might find some women feel that no radiation is the right amount.
Ken, what are your thoughts on this?
Well, there's a few high-level things. If you really dig into the literature on radiation and genetic effects, you'll find that the only study that's shown genetic effects of radiation in mammals is on mice, and the exposures, the doses were 1 gray. That's over 1,000 times higher than we're talking about here. We referenced earlier in the discussion that the fetus is at different risk levels based on the trimester. Well, all of the papers would say that those risks really don't become relevant until about 100 millisieverts. So now we're 100 or 1,000 times higher again than the dose estimates here. The other thing I think, and there is some variability between the U.S. limits, the U.S. limit and the European limit. That's, I think, okay. The European limit is a little bit more conservative than the U.S. limit. But if you think back to that graph I showed, the background radiation that the fetus is going to get is higher. So the background radiation from natural sources, from cosmic sources and earthly-based sources, that radiation is higher than these fetus dose estimates from working in the cath lab. And so, these are very low values, and all of the papers, the research that you will go back and look at for yourselves would suggest that the risk is really, really low, much, much lower than other risks to pregnancy for interventional cardiologists.
Mayra, it seems like there's been growing interest in this subject, in this space. Should studies like this really push the field forward, not just in terms of women feeling comfortable going into interventional cardiology, but pushing advanced radiation protection systems? SCAI and others have talked about zero radiation is a moral imperative. Should these types of data push the field forward into more advanced protection devices?
Well, I think it's important to maximize the protection. It will never be zero. But I think it's more reassuring. It tells us that what we wear on a regular day, it provides enough protection. So the exposure is really low. I think it's reassuring. Maximizing radiation, then yes, of course, is always good. And also what you mentioned earlier about orthopedic problems, that's another barrier. So finding the right balance between too little and too much, I think that's going to be the secret. But at least I feel reassured that even when we don't know we're pregnant, as long as we're wearing proper protection on a daily basis, we should be protecting enough, our babies, and they will be receiving less exposure than natural sources.
Let me ask you something, Holly. If you were advising SCAI and the societies, what would you advise them looking to the future in this field?
I think it's really important for us to educate our male colleagues on this topic as well. I can say as a trainee, there was not a lot of discussion about female interventional cardiologists in pregnancy. And in fact, some of the advice that may have been floating around was not the best advice. One of the things that we were just speaking about internationally, some women are not even allowed in the cath lab. Can we, as a SCAI community, advocate for women in interventional cardiology and really create some policies based on data such as this paper and also some of the background data that we all know about, and come to a consensus so that we can promote female fellows coming into the cath lab safely instead of maybe the narrative changing from place to place.
Celina, I'm going to give you the last word. And if you see the published studies on some of these advanced radiation protection systems, actually 75% of the cases are zero radiation to the operator, the scrub nurse, and the fellow. I asked Mayra this question. Do you think as close to zero, when we talk about ALARA, if we are still getting radiation to the head, the neck, the face, the arms with our standard protection now, is that not in fact a violation of the ALARA principle? Now knowing that we have these more advanced protection systems, say Rampart, say Agnest, say Protego, et cetera.
Gosh, you're right. A few years ago, this would have been a really depressing topic because there weren't options. And I think in the last few years, things have really changed. I'm there with that live monitor, and I can see when I move from room to room, the rooms where I'm in with Rampart, for example, there is zero radiation.
Right.
I mean, that's a reality that I could see becoming more commonplace. And I think if we can get to a point where routinely we're experiencing undetectable levels of radiation on a consistent basis, I think we're going to have a really good shot at capturing that last group of bright young women who are interested in the field, but still have some of those residual concerns.
Well, I'll tell you, as the father of 4 daughters, I can't think of any better way of ending this, and there's nothing more important to me than to make certain that there are no prohibitions or barriers to women choosing a field in interventional cardiology, one of the fluoroscopic specialties. I want to thank each of you. This is a really, really interesting topic. This is I think there's a treasure trove of new data and new information. And I don't know how many of you remember in his presidential address to SCAI, Jim Hermiller called this whole burgeoning field a moral imperative for SCAI. So I want to thank each of you for joining us, and I want to thank Alexander Lansky for putting this together. I think this is an incredibly important topic. Thank you very much. I'm David Rizik from Honor Health for SCAI.